Then we come to posterior knee complex. We scan Semimembranosus-Gastrocnemius Bursa. We scan for posterior vessels, and we scan for posterior cruciate ligament. Here is posterior cruciate ligament and posterior horns of the lateral and medial menisci. If we scan this area for Semimembranosus-Gastrocnemius Bursa, we get it normally, and if there is Baker's cyst, we can get the Baker's cyst there. There is a Baker's cyst in that region. For posterior cruciate ligament, we place our probe in this direction obliquely. We have to scan this structure. We get this type of view for posterior cruciate ligament. Then we come to knee pathologies. First is Suprapatellar Bursa. We scan this area, and here is bursitis. Fluid in Suprapatellar Bursa. This is called Suprapatellar Effusion in the recess. Then we can have loose bodies in Suprapatellar Bursa, which will be hyperaquic with shadowing. It can be confirmed in short axis. We can have Lipomata Arborescens, spindle shaped projections within the joint. Here it is again, and usually seen in some cases of arthritis. A Pannus formation in rheumatoid arthritis. Here is the Pannus formation at short axis. Coming to Quadriceps Tear of the vastus medialis. You can see the discontinuity in the tendon, and we are scanning this area. Quadriceps tear again, you can compare with the contralateral side. This is normal side. Here we have tear in vastus medialis. This Quadriceps Tendinitis. You can see patella with quadriceps tendon inserting on patella, and here is inflammation of the this quadriceps tendon indicating tendinitis, hypoaquic inflamed area. And another case showing tear in quadriceps tendon before it is inserted. There is another case showing tear in quadriceps at different levels. Then coming to patellar tendon, long axis of the patellar tendon, and this is inflamed area indicating tendinitis near to the insertion in the proximal part of the patellar tendon. And chronic patellar tendinitis, this is proximal part of the patella and the distal part of patella. You can see that there are hyperaquic areas indicating chronic patellar tendinitis with calcified areas. Focal patellar tendinitis is another thing, and this is a case in the distal patellar tendon. You can see that a focal area is inflamed. It can be due to some trauma. There is inflammation indicating tendinitis. This is transverse and longitudinal view. Patellar tendon tear is very easy to diagnose. If we look at the patellar tendon and we follow it longitudinally and transverse, we can see discontinuity of the fibers indicating tear of the patellar tendon. Here is prepatellar tendinitis. This is patella, and just above the patella, the prepatellar bursa is inflamed, thick walls and fluid in it. Infrapatellar bursitis can be seen. This is superficial. Here is infrapatellar tendon. You can see its proximal part and distal part. Patella, tibial tuberosity where it is inserted. So just anterior to that is the infrapatellar bursitis, which is in the superficial bursa. Osgood-Schlatter's disease is another case which can be diagnosed on ultrasonography. Then coming to medial collateral ligament, A ligament strain is very easy to be diagnosed. On ultrasound, medial collateral ligament takes the brunt of a valgus injury, hypoequic swelling of the ligament, and usually occurs along the femoral aspect, but sometimes along the tibial component of the medial collateral ligament. Here we can see the strain, inflammation, and few fibers are torn. Here you can compare it with the contralateral side. This is swollen, acutely swollen medial collateral ligament, and on the contralateral side, on the right side, it is normal. So area is increased, hypoequic. For ligament tear, a partial thickness tear may involve either the superficial or deep layer. The deep layer is most commonly torn. Unlike MRI, musculoskeletal ultrasound can distinctly delineate the laminar medial collateral ligament integrity. Most tear occur at the femoral segment. Here is the torn area of the medial collateral ligament. This is medial collateral ligament, and the torn area at the femoral side. Here it is, torn area, the medial collateral ligament, and some inflammation is there. This is the magnified view of the same. The zigzag tear. You can see the zigzag path of the tear in medial collateral ligament, and here we have again zigzag path, which was confirmed on MRI. Then coming to lateral collateral ligament, the most common site of the lateral collateral ligament is a strain. Full or partial thickness tear can occur and often are at the level of the tibial condyle. Here you can see partially torn lateral collateral ligament, inflammation, and this is normal on the other side. Again lateral collateral ligament, and these are the torn areas. Iliotibial band bursitis often affects runners. Chronic stress between the iliotibial band and the lateral femoral condyle causes the bursa in between to swell with fluid. A hypoequic distended sac is seen. Here you can see iliotibial band. This is called iliotibial band syndrome, in which there are few sprains or torn areas with inflammation. And meniscal tear is very easy to diagnose on musculoskeletal ultrasound as compared to MRI. It is expensive and very easy to perform. Its accuracy rate is 97.5%. Seen as the cyst, meniscal cysts are seen as hypoequic focal cystically resting at the hyperequic triangular meniscus. Valgus stress applied to the knee would help distract the hypoequic cleft of the meniscus. Lateral meniscus is more common, and here is non-stressed lateral meniscus cyst. After stress, you can see it is not separated at the long axis, and we can see on real time at long axis that by giving stress, the cyst is not being separated from the meniscus. It is originating from the tissues of the meniscus, so confirming that it is a meniscal cyst. Menisculocapsular separation is another pathology, a separation of the meniscus from the capsule, and may mimic meniscal cyst. However, menisculocapsular separation often demonstrates a fluid distraction widely wrapped over the meniscus, extending well above and below the joint line, which is called pancake type of layer. May have hypoequic meniscal tear seen. There is menisculocapsular separation. There is meniscus, and you can see the capsule is separated, and there is a pancake shape area which is separating the capsule from the meniscus. Then in posterior knee, we look for Baker's cyst, aneurysm of the vessels, as we have popliteal artery and vein there. We can have venous thrombus in the vein, hematomas, posterior cruciate ligament tear and ganglion cyst. Here we have a Baker cyst, another ruptured Baker cyst, and a dissecting type of Baker cyst. This tibia and gastrocnemius. Then coming to posterior cruciate ligament, left oblique popliteal fossa is scanned. We put our probe in oblique direction in the posterior popliteal fossa, and here is the posterior cruciate ligament, and you can see popliteal fossa ganglion cyst. There is fat, posterior cruciate ligament, tibia and femur, and this is ganglionic cyst. So in conclusion, we can say that in knee we can scan extensor mechanism, we can scan bursa, synovium, extra articular structure, popliteal fossa. Thank you very much.